Thank you very much to the Triple J practice for inviting me to talk. I really appreciate the opportunity. Gave me a little tiny topic, which is cardiac arrest while on ECMO, and 20 minutes to do it in, so here we go. Okay, next slide, please. Usual disclosures, I'm not earning any money from this, hint, hint. It does contain personal opinions. There may be errors. Please check everything I say before you implement it on a patient. Okay, next one, please. I'm going to focus on having a patient who's on veno-venous ECMO, a patient with lung disease where we're predominantly trying to support oxygenation. Because in that patient, when the heart stops beating, you've got a major problem. In theory, at least, and when you're on veno-arterial ECMO, you can always take over the heart flow, even though you still have to try and get the heart going, but you've got a bit more time. So in veno-venous ECMO, the heart is not replaced, and your organ perfusion depends on having a native cardiac output, and actually, the flow of blood through the system that ultimately feeds into your ECMO machine depends on having a native cardiac output. So if the heart stops beating, you're doubly in trouble. Next one, please. So, I've said this before, if you don't have a cardiac output, there's no blood flow. And very rapidly, there's no oxygen delivery to the vital organs, and pretty much in order, the brain, and then the heart, and then the kidneys are going to fairly rapidly die. You've got a couple of minutes before the brain starts having irrevocable injury. And although it's not the correct term to use, if you're not getting flow to fill up the ECMO machine and give you a venous drainage, the system is effectively going to stall as well. So we've got to get it fixed. Next one, please. Now, there are lots of cardiac arrest algorithms that you can find. You can download excellent ones from the Resuscitation Council of South Africa. The problem with wall charts and so on in my brain is that I'm never close enough and I can't see the wall chart to get to them. And so I'm very much a person who likes to make mnemonics about everything. Now there's already an existing mnemonic for cardiac arrest. Basic life support is now call a cab. When I was working at Gray's, I had to make a longer mnemonic for guiding the advanced life support thing, and I came up with call a cab driver. But for this one, because we've actually got many of the things dealt with, a patient who's on ECMO is going to be monitored. He's going to have intravenous access. There's a whole lot of stuff we don't have to worry about doing. I've shortened it a bit. So the whole challenge is here is a South African challenge. Are you brave enough to ride in a South African taxi? So this is the Call a Cab DARE. And it's a system to help you manage the chaos. So next one, please. The first word of this is call for help. When the patient has a cardiac arrest, in fact, any ECMO emergency, guaranteed you cannot manage this completely on your own. When you've got a patient on ECMO, you've actually got two patients. There's the real patient, and then there's the mechanical patient that might be the cause of the problem or might be suffering because of the cardiac arrest. And you need to have attention to both. Thinking about it, I think for a full-blown cardiac arrest, you're going to need a minimum of 5 people, practically more like 7. Now, we all walk into units and we'll see for the day, here's the allocation of duties in the event of a cardiac arrest. Such and such a person will be the team leader, and someone else will do compressions, and someone else will do this. And I've never, ever in 20 years seen those systems actually work out, because guaranteed, when the arrest happens, 3 of those people are at T. And guaranteed, there's going to be some poor oak next to the unit when it happens who's not on the list. So those things don't really work at the beginning. You need to have roles assigned because people mustn't get into each other's way, but you need to have systems based on how people actually arrive. So again, at Gray's ICU, we had a system for a resusc for the first person there was rescuer 1, and they had a role, and the next person was rescuer 2, and they had a role, and then there was rescuer 3. And when everybody was there, then you could shuffle around, and you had to do that. Now, I'm not going to go into a detailed system here, but you need to make up some type of on-the-fly plan like that. What is important is that at the beginning, there's a whole lot of things to do by rote, and anybody can do them, and everybody that's in the unit should be able to do them. When the whole team is there, then to get a successful resusc, you need direction and you need a controller, somebody who can oversee and, most importantly, not be touching the patient. Because the minute anybody's touching the patient, they're not directing the scene. So that's an important thing to think of. And just team dynamics to make a resusc work, you've got to have bi-directional communication. If I'm that happen to be the team leader, a very unfortunate job to be in, and I speak to a person, if I don't know their name, often don't, I need to indicate clearly who I'm doing, ask, will you please draw up 10 moles of calcium chloride? That person has to tell me back, I'm drawing up 10 moles of calcium chloride, and then come back later and say, I've got it ready. That type of bidirectional communication is really, really important. Okay, you need a team, you need to call them. Right, next thing. Next slide, please. When the heart stops pumping, and a patient on VV-ECMO, there's no blood moving to the organs. And the immediate, absolute priority is to get blood moving. You're doing that mechanically by doing chest compressions. And the closest person to the patient, irrespective of what they're assigned to on the list, must jump on that chest and get compressions going. So we're physically going to do chest compressions that will compress the heart a bit, will compress the lungs a bit, work together as a pump and move blood around. Chest compressions, even done optimally, at most generate 20% of your normal cardiac output. So you've really got to do them well. And important points that are now well established. You should be doing them at a rate of between 100 and 120 a minute. No slower than that. You've got to keep interruptions to an absolute minimum. Because if you stop even for a fraction of just more than a second, your blood flow that you've established will stop, and it will take at least 8 compressions to get your blood flow going again. So you must not stop if you can avoid it. The depth in an adult is about 5, minimum to about 6. God knows how you exactly get between 5 and 6 centimeters, but that's the recommended depth, about 5 centimeters, or about 1/3 of the chest wall in a child. You need to be pushing onto a hardened surface, and that is a real problem because we've got lovely soggy beds and air mattresses. You need to have the rapid ability to put a board under the patient, and if your patient happens to be on an inflatable mattress, know how to deflate that mattress. And some do deflate rapidly and some don't, and that could be a real problem. If you've got a non-deflating soft mattress, your chest compressions may not work. Okay. Now, the good thing about being on an ECMO patient is that guaranteed you've got hemodynamic monitoring. And often we're querying how well are our compressions working. There's also a thing, you've got to have a competition between all the compressors to see who's the best. But now you've got an A line so you can look at it. So what are the guidelines for efficacy? What you're aiming to achieve is a diastolic blood pressure, because our one immediate goal is to reperfuse the left ventricle of at least 25 and preferably 30 millimeters of mercury. If you could simultaneously measure CVP and arterial pressure, you'd want the difference to be more than 20. But frankly, just focus on the A line, get the diastolic pressure more than 30. That seems to be efficacious. And although I've left the units out over there, if you've got a capnograph, which none of us units actually have, but we really should have, because it's an essential safety tool, we should be trying to generate enough blood flow so we're generating an end-tidal carbon dioxide of at least 20 millimeters of mercury. Okay, right. Those are chest compressions. If we don't do them, everything else is a waste of time, and we need to do them well. And when people get tired, we need to swap people over. Okay, next slide, please. Okay, so now here's actually the summary slide of everything. That's the full sequence. I've done the important things. Get help, do chest compressions, and then we think of it. What do the other letters stand for? Airway and breathing, defibrillation, giving adrenaline, finding the reason for this mess so we can fix it, and then looking at specific ECMO factors for this patient. Let's go to the next slide and move along that list. Okay, so airway and breathing. Now, not to focus on it too much, 99% of patients on, especially VV-ECMO, probably 100% of patients are going to be intubated and ventilated. Just check that the airway hasn't come out and make sure that that's secure. If you do have a cardiac arrest while you're managing it, you've got to change your ventilation. Now, we're generating very little blood flow with compressions. If the lungs are overinflated, you'll get zero blood flow through them. So you've actually got to ventilate the patient less. So, straight away, patient has an arrest. If they're on a ventilator, even if it's not doing very much, because we're doing lung protective ventilation on this guy with shot lungs, put it on 100% oxygen. Immediately drop your PEEP to zero. You cannot have retained air in the chest in a zero cardiac output state. Now, if you're thinking, well, my guy's got terrible lungs. If I drop the PEEP, I'm going to lose all my recruitment. Yeah, that's the problem. It's a disaster, but you've got to do it. Otherwise, the heart's not going to, you're not going to pump air. Put it at a slow rate. The recommended rate is about 10 breaths per minute, which is nice and slow. A tidal volume of just 6 mils per kilogram. And disable the high pressure alarm so that when you're pushing on the chest, it doesn't keep aborting because it's measuring the chest pressure. Now, if you've got one, so unit policies now differ. What do you do with ventilation during a cardiac arrest? Those are the things that you have to do if you want to keep the patient on the mechanical ventilator, which is not a bad thing to do because at least your hands are free, then the ventilator can work. Newer machines, there's now an international standard that are coming out, and new machines made in the last 5 years incorporate a CPR mode. When you switch it on, it'll automatically do those settings, disable the pressure limits and so on. So the Mindray SV800 does that, the SV300 does it, and some of the ones from GE will automatically have that mode. Hopefully all machines will have that. In the meantime, if you've got an older ventilator, you're going to have to program that all in. Can you do it? Can your staff do that? If not, maybe it's safer to grab a Babgirl mask and use that. In this case, a BVM without a PEEP valve. Problem with a BVM is that everybody gets excited, and what do you see your BVMer doing? They're pumping, 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 because they're all getting excited, and we defeat the object of the exercise. So if you do have a patient who's being ventilated by a BVM, make sure it stays slow and not too big. Otherwise, it'll defeat the output from your chest compressions. Okay, next one, please. Okay, defibrillation is an absolutely essential thing. Now, the good thing again about ICU patients is that they'll be on an ECG, and straight away, as soon as you see the arrest, you should be looking up, and if you see they're in ventricular fibrillation or pulseless ventricular tachycardia, you know there's no cardiac output because the heart is just quivering, and you all know the immediate thing is to defibrillate them as soon as you possibly can. Hopefully you've already got stuck on pads and don't have to use paddles. For the energy settings, every manufacturer has their own recommendation as their way to start. If you've done that for the first shock and it hasn't worked, go to maximum energy for the rest. Remember, you're going to do one shock and repeat it after 2 minutes. When you've given the shock, do not expect the patient to immediately come out of VF. And in fact, the recommendation is you give the shock and you immediately restart chest compressions to get blood into the heart, and you only really look at the heart again 2 minutes later when you're checking whether they're going to do it again. So don't shock and wait. Oh, is he out of EF? No, not really. No. It's shock and back on compressions. If you've given a couple of shocks and the patient remains in VF, it is also in the recommendations to give a bolus, not an infusion, a bolus of amiodarone to try and make the heart more defibrillatable. There's also currently, they've reintroduced the option of lignocaine instead of amiodarone at this stage to reduce AF. The evidence base for amiodarone is really based on one trial, not a very big one, but it's there and it seems to work, so do that. 2 or 3 shocks not working, amiodarone bolus or lignocaine to try and improve the defibrillatability. Next one, please. Okay, adrenaline. Adrenaline is in this case a vital drug to give. We're going to give our adult patients 1 milligram. What are we giving it for? We are not giving it to stimulate the heart. We're giving it to make the blood vessels contract and centralize the blood so it's in the heart and the brain and not in the big toe. We don't want the cardiac effect, funnily enough. There are alternatives to adrenaline like vasopressin. They cost more and they don't really work any better according to the current available information. You give your first dose of adrenaline as soon as you can if you've got a pulsus electrical activity or asystole or non-VF arrhythmia. Technically, if you've got a VF, they want you to try and at least do 2 shocks before giving adrenaline. And the logic of that is that if you otherwise overstimulate the heart with adrenaline, you may perpetuate the VF. To be honest, to train people not to give adrenaline if there's a VF is really, really difficult, I've found. That's a bit of a challenge. It might be better to just say, you know what, as soon as the adrenaline is there, get it in and get on with it. But do whatever you want to do. The other thing is you don't want to give too much. The official recommendations say give it every 3 to 5 minutes. I'll stuff that, just give it every 4 minutes. If you're doing 2-minute cycles and you're defibrillating or looking for a defib every 2 minutes, after every 2 of those cycles, it's 4 minutes, it's time for another dose of adrenaline. Overdosing adrenaline worsens your outcome. Turning open your adrenaline infusion worsens your outcome. It's very challenging. Now, Kath spoke a lot about preparation. There's one very simple preparation that I found to be phenomenally useful and has really saved time in resuscities that I've been involved in, especially at Grays. And that's to pre-make up your dose of adrenaline or at least have the tools for that. Instead of just giving 1 little mil and then trying to inject it somewhere and flush it in and you lose half of it on the bed, have the system and you've got your amp of adrenaline, a 10 mil syringe and a needle, and 9 mils of saline to draw it up. Automatically draw up your amp of adrenaline, dilute it up to 10 mils, and now what have you got is an instant all-in-one bolus and flush. And if you're using a pediatric patient, your dosing is easy because it's 1 mil per 6 kilograms. So I think it's really useful to have it. I also really think it's a good idea in every cubicle to have that little packet of 4 things, adrenaline amp, saline, syringe and needle, bound together with a little elastic band and available. And so straight away, as soon as you walk in, as the team assembles, someone says, I'll grab the adrenaline, they automatically draw it up and it's ready to go. It is really, really cheap. Even in private hospitals, the amount you're hashing for the patient is really, really low. And it saves a phenomenal amount of time if that's in the cubicle and you don't have to run to some drug trolley. Okay, next one, please. Okay, now, the patients had a cardiac arrest for the reason everything we've done so far is just keeping them going. We've got to try and reverse the problem. The classical the list of things to go for are the 6 H's and the 6 T's, which funnily enough were originally invented by Walter Klook from South Africa. They're now in the international guidelines, but they're a South African invention. I've added a letter A specifically for ECMO, and you've heard about air embolisms. I've added that in over here. Those are the 6 H's and 6 T's. I'm not going to go through all of them. I'm just going to highlight a couple that really matter for our setting. Next slide, please. So some reasons. Could the patient have arrested because they were hypoxemic? Absolutely. Is that because they had crappy lungs and you weren't ventilating them? Check that if they are dependent on some degree of ventilation, is the tube not out? Is the ventilator working? Sometimes it's the patient factors. They're so hypermetabolic, they so completely deoxygenate their blood, nothing can oxygenate them. But also in the ECMO setting, look for obvious things. Like, have we stood on the oxygen tubing? Is the oxygen connected and actually flowing? Have we bumped the Secret blender? Is the oxygenator working? Thanks, Ashlyn. Is it clotting up? may not cause an acute request, but sometime when it's failing, it's going to lead to a cardiac arrest. Is our gas flow high enough? Maybe we bumped it down. Who knows? And is our cardiac flow actually high enough to meet the patient's needs? So could you have arrested from hypoxemia? Think about the options and reverse them. Next one, please. Hypovolemia. Patients lose fluids into tissues from the inflammatory response. If they have a blood leak somewhere, they bleed. We know that they're going to get a cumulative intravascular fluid deficit. At some point, that's going to be too little to fill the heart. Obviously, look for hemorrhage. And we've mentioned patient-related bleeding, cannula site-related bleeding, and disruptions of the circuit. Look for all of those. Sometimes you're not sure. Is the patient behind on fluids? Could that have led to something? It is really useful to have the ability to do a rapid echocardiogram to look for it. And having an on-site ultrasound is actually a recommendation and requirement in a European ICU system. Okay, next one, please. Electrolyte changes. Any kinds of things can cause chaos. Just to highlight one thing. So straight away, when you get in there and the patient's arrested, you're going to get an ABG. The iStat is a lovely device, and there are other point-of-care machines that give you the same information even quicker at the bedside, whatever. Do that. Just want to highlight hyperkalemia. It's going to be a very common cause of cardiac arrest. We have lots of patients with kidney failure. We might have patients that have come back from having a bypass and have had lots of potassium put into their systems. The point is that if a patient arrests from hyperkalemia, you're not going to be able to stop that by doing insulin shifts and giving all that sort of rubbish. The only way of stopping a hyperkalemic arrest is to antagonize it immediately with calcium. And to antagonize that, you need at least 10 mils of calcium gluconate or 30 mils of the more dilute calcium 10 mils of calcium chloride, that's more calcium ions, or 30 mils of calcium gluconate. In fact, if you know the patient's arrested from hyperkalemia, because you can see the potassium is 7 and you've seen the broad complexes before the arrest, give the calcium even before you give adrenaline. I've personally caused 3 hyperkalemic arrests by giving a patient scoline when I shouldn't have done, and in 2 of them by giving calcium immediately, I got the patient back. I've been involved in a couple more, and it's amazing how well calcium works. But you've got to have calcium there, and you've got to be planned to give it already. Now, in preparation, again, I think those adrenaline bundles are useful. If you're worried about a patient having hyperkalemia and going that way, why not have calcium also in the cubicle? It's cheap. 1 amp of calcium chloride with the stuff to draw it up and give it is cheap and available. That can save the patient's life. You've got 2 minutes a window before that's no longer useful. Use it. Okay, next one, please. Tension pneumothorax. Especially with COVID, we saw millions of people blowing pneumothoraces. Even if we try and do ultra-lung protective ventilation, they're going to pop pneumos. And so we can't completely not ventilate them. They'll always have a barotrauma risk. Sometimes they accumulate insidiously and there's a slow BP drop. Sometimes there's a sudden tension and suddenly you don't know why the patient's having a cardiac arrest. One has to be very suspicious because you often can't hear anything. Again, an ultrasound at the bedside can in 2 seconds give you a rule-in, rule-out decision. Now, when I was training as an ILS paramedic, God, was that 30 years ago, the one line was, hey, if in doubt and you can't hear entry, stick a needle into it. Absolutely. Yeah, that was very important in Alexandra Township at that time. The problem here is if we just randomly stick needles into patients, we've got to put a drain in. And patients will bleed from the IC drain sites. And they can bleed to death from that. In fact, if you look in the blue book, it often recommends don't put drains into small pneumos. Watch and wait them out. You can't do that if they've got a genuine tension pneumothorax, but you don't want to put a drain into a patient who doesn't have a tension pneumothorax because they're going to bleed from that. So be cautious about that and try and lure it in. But you have to think about it. Next one, please. And I'm not going to talk about cardiac tamponade. And I thought Dr. Fulton was doing this one, but apparently it's Dr. Chen, so apologies, but you'll listen to him. Right, next one, please. Thrombosis, can these patients shoot pulmonary emboli? Absolutely, from cannula sites, especially when you've taken them out. But they could anyway suddenly get obstructive shock, often can't do anything. What can you do about them? You can't immediately give them thrombolysis. You're going to carry on your compressions. If you have a small clots, often you can actually break them up by just simply doing compressions for a while and they'll break up. If you've got a massive clot, you won't get the patient back, but you're going to try. And again, trying to work out what's happening. A bedside echo to suddenly see right ventricular distension can be incredibly, incredibly useful if we have it in the unit. Okay, next slide, please. Can the patient have an MI? Absolutely. We're typically not going to get too many of the classical type 1 epicardial myocardial infarctions, but these patients are often septic. We're doing VV-ECMO, will have high cardiac outputs, poor perfusions, and may very well be prone to a subendocardial type 2 in myocardial infarction, where their oxygen demand is higher than their oxygen delivery. And yes, having a look at their heart with an echo would really help you again to make that diagnosis. Next slide, please. And then lastly, air emboli, which you've heard of a lot. One of the things that haunts me forever is a 21-year-old nurse at Baragwanath Hospital who had complications of her pregnancy, developed renal failure, and she was going a bit off, and she had a creatinine of about, 400, and a little bit hyperkalemic. But you know what? I thought, yeah, well, let's put her on dialysis. You don't really have to, but yeah, we'll get her off the unit quicker. And she was the one, we're on a simple dialysis circuit, there was a disconnection, and she got an air embolus, and she died incredibly fast in front of us. And that was horrible. And what we tried didn't work, and we couldn't get her back. And she died unnecessarily, because I didn't really need to put her on CVBHD. Air emboli, when they do develop, are horrible. So looking at all the things, looking for developing emboli is really, really, really important. Look for air entrainment. And we've been through now multiple things about air in the system. I must admit the classical thing, when you're aspirating air, put them head down, try to suck out the CVC, doesn't really work that well because you usually don't have time. And remember, an arterial air embolism, as little as 10 mils can be lethal, where a venous air embolism, you only need about 100 mils to be lethal. Not that that helped that nurse who had a venous air embolism. Okay, last slide, I think. Yeah. Okay, sorry, not second last slide. You've also got a second patient. When the patient's had a cardiac arrest, somebody has to go back and look at the machine while everything is happening to the patient and check the entire circuit and all the possible causes. Remember, VV-ECMO may not drain very well at all because there's no blood flow. You may need to turn down your RPM, so you're trying to suck less blood off. Conversely, if you're on VA-ECMO, maybe turning the flow up to take over from the heart that isn't working would be logical. So it's two different settings. But VV come down on the RPM, VA go up and take over from the heart. Okay, now I think it's the last slide coming up, which is just a recap of the same things. Have a sequence, do something, whether you like that scheme or something else, who cares, but work in sequence. Think of the causes and try and reverse it to try and get your cardiac arrest patient back. Thank you.